So this is why we've now changed to robotic assisted surgery. And we will explain now the differences between the manual surgery and the robotic surgery. The manual surgery involves using jigs which are placed on the bone. So generally speaking, the patient will be positioned on the operating table, and once the surgeon gets into the knee joint, he'll put a jig, what's called an extramedullary manual device on here. He'll pin that onto the bone, and that will be used to manually cut the bone. Retractors will be placed at the back of the knee to protect it. Really, the surgeon doesn't have too much control how close he can go to the edge of the bone, as the saw itself will dictate that. On the femur, a rod is put into the femur, and again, you don't have too much flexibility because the rod goes where it goes, and then the bones are cut for everybody. So everybody essentially gets the same cuts. They're cut flat on the tibia, and they're cut which is on the femur based on what looks like the best position. In the robotic surgery, we now have the technology that patients will have a CT scan. So their surgery is not based on the X-ray, but it's based on their own unique anatomy. So if your femur is bigger than the tibia or vice versa, a precise CT scan will show you the exact anatomy that you have. This CT scan will then be sectioned. Lots of slices are taken to give detailed information. And at the moment it's sent to Florida in America, where they will compose a plan which comes back like this model here. So it will show you for your knee what the best size is of the femoral component here, so the best size for the fit. It will show you the best size for the fit for the tibial component, and it will show you where to position the implant. So this allows the surgeon during the surgery to make, even before the surgery, to make fine adjustments to make the implants fit the knee for the best position. So in other words, say for example, the implant looks too big, you can narrow it. If it looks like it's going to be too large, you can make it thinner in this angle, or change the angles. And what you do is you customize the knee before you even start the surgery to get the best possible fit, both on the femur and the tibia. During the surgery, you will have live feedback in terms of where the knee is. So you can make adjustments, so you make sure that there's no excessive laxity either side. You make sure that the knee bends fully. It gives you an angle of bend. It gives you an angle of extension. So you know categorically that the knee is extending to a certain amount, flexing to a certain amount. Now, the three-dimensional technology has a few advantages. One is that the planning is very accurate. Secondly, there are no longer jigs, because the information now will be fed into a robotic arm, which will essentially make the cuts. So in a conventional knee, you have to dislocate the knee to make the cut on the tibia. You have to then make the cut on the femur. And there's a lot of manipulation of the knee. In a robotic knee, there is no manipulation of the knee initially. So the cuts are made with the knee in position, because the technology has what's known as haptic technology. It will not allow the surgeon to go outside the bony window. So if the saw is taken outside the bone, it will stop. So you have very minimal damage to the bone and the soft tissues around. And that applies to the femur, and it also applies to the tibia. So in the robotic knee, the cuts are made in position, and the only time you manipulate the knee is right at the end when you put the tibial component in. So one time you have to move it back, and then you move it back into position, and then you put the femoral component on. So this lack of manipulation, this very precise technology in cutting, we believe is the way forward and has become the gold standard. We've now been doing a number of cases. We've done over 400, and we've seen excellent results. Patients have minimal pain, which means that they have minimal soft tissue damage, less swelling. And if your pain is controlled, you start to have early movement. You can walk more comfortably, and you can then achieve a quicker recovery. There are going to be some patients, who do have pain after the surgery, and some who do have what was known as neuropathic pain. And that would happen whatever surgery they had. But for the majority of patients, we see a better range of movement, better recovery. And the reason this happens is, number one, your implants are chosen to be bespoke for you. There is no eyeballing. There are no manual jigs which create errors. So you're fitting the components in the best possible position for your anatomy. Number two, when you're making the cuts, you're not manipulating the knee. You're causing minimal damage around the bone, soft tissues. Minimal damage means less swelling, less inflammation, which means less pain. So you're going to get earlier movement. We're seeing lots of patients at 2 weeks are walking now without crutches. We're seeing patients who are taking paracetamol, brufen early on rather than morphine. And as a result, the recovery is quicker, and the results so far with our patient series have been excellent. We're collecting the data, we're presenting that data nationally, showing the excellent results. So that, in summary, is what a knee replacement entails. Thank you.